credentialed by CASA to conduct eye examinations for pilots. When I came to Port Lincoln, I was here on a placement, so that was in my last year of uni, and I fell in love with it, and I asked for a job, and I've never left. So that was 7 years ago now. I started at Air Eye Centre in 2015, and now, as of last year, 2020 is 2 years ago, I am now a director as well, so that's a nice little progression. I do have a very big passion for improving quality of life for all my patients, and also to educate them on their conditions and make sure they understand what's going on. My other passions, other than optometry and eyes, include my dog, and I'll show you a photo of him. So that's Scooter, my dog. And I also love snow skiing. So I was brought up on skis, that's me when I was about 2, skiing down the slopes. And I do love looking at the beauty in the world and admiring pretty sights and things like that. That's one of my other passions as well. Any questions so far? No? So what I'm going to cover today is just a little bit of a background on ankylosing spondylitis, just so we're all on the same page. You all probably know more than me on it, but we'll just revisit, and maybe it's a bit of a refresher for some of you. And we'll do a little anatomy lesson on the eye. And also, obviously, we'll go through the complications of ankylosing spondylitis that happen to the eye. So like the symptoms, signs, treatment and complications, and we'll visit a few of those. And please, if there's any questions, interrupt. And also the live streaming people, please interrupt as well. Okay, so ankylosing spondylitis comes under a big group of seronegative spondyloarthropathies, it's a mouthful, which is a group of multi-system inflammatory diseases that affect the spine, peripheral joints, adjacent soft tissues and the extra-articular structures. Now, seronegative means that the antibodies aren't detected in the blood, and it's a different mechanism of disease rather than the seropositive. So most of the conditions are associated with HLA-B27, which is a protein on the surface of the white blood cells, but they don't all have that. So just because you are positive for HLA-B27 doesn't mean you have a condition, and vice versa. It just increases your risk of developing a spondyloarthropathy. So a few examples are listed here. So obviously ankylosing spondylitis, which is what we're going to go into, but the other spondyloarthropathies are the Reader's syndrome, psoriatic arthritis, inflammatory bowel disease, associated arthritis, and that's an undifferentiated spondyloarthropathy, so just none of the other 4. Now, I'd like to start with this picture. So this is a very nice summary that I found on the internet that another lecturer has drawn up, which is a really nice summary of what happens in ankylosing spondylitis. But essentially, obviously it's a chronic progressive inflammatory disorder that does primarily affect the axial skeleton. It is quite disabling, potentially, depending on the severity, obviously, and inflammatory spinal pain, as you're probably all aware, is the main symptom. Does everybody get that? Yep. And obviously with time it can get worse, and so some patients develop the spinal immobility. I had to look up what an enthesis was, so which was this was a nice little refresher for me too. So because the pathology mainly affects the entheses, so that's where the ligaments, tendons, and capsules are all attached to the bone. And 3 processes are observed here: so inflammation, bone erosion, and spur formation. Now, with HLA-B27, so out of all of the spondyloarthropathies, it has the highest or strongest association with ankylosing spondylitis. They don't really know why, but it just is. But over 90% of Caucasians and 60% of African American patients with ankylosing spondylitis are HLA-B27 positive. So it's quite strongly associated, but again, not 100% of people with it have it. But the role of HLA-B27 in the eye complications is actually unknown. Well, it's not exactly known, but there are lots of theories which we could go for hours on about those, so I'm not going to go right into those. But you just got to know that it just can, it is related in some way. So the HLA-B27 being positive for that does increase the risk of certain eye conditions if you have AS as well. So just got to be aware. You can get inflammation associated with HLA-B27 just on its own, or in association with a spondyloarthropathy. So sometimes so half of patients who have HLA-B27 or are positive for HLA-B27 and they get eye disease, half of them will actually be diagnosed with a spondyloarthropathy, which is quite high. So I often do refer people for the testing for the HLA-B27 antigen. Even though it doesn't really say that you have a condition, it's still good to know. And I'll go into why that is in a moment. Am I going too fast? No? Cool. So why is HLA-B27 important? Now, like I said before, it's not necessary to have this to establish the diagnosis of ankylosing spondylitis, but it is really useful in determining what might happen in their uveitis when they get it, or how long it might last for, or how severe it will be. Because people with both ankylosing spondylitis and HLA-B27 antigen, they tend to develop the eye problems at a younger age. They tend to have a longer duration of disease. They usually have more recurrences, and they appear to have more severe disease. I had a 19-year-old patient a few weeks ago who didn't say he had ankylosing spondylitis, but I'm sure he did, because he had back pain and lots of other inflammatory issues for a long time, and his uveitis was very bad. So I was sure he had it, so I did send him for testing. But yes, it can happen at a very young age. So the spondyloarthropathies, like I mentioned before, that list of including ankylosing spondylitis and the others, the eye issues can definitely occur with any of them, and the frequency of them and the type of ocular findings do vary with all of them. Now, it's really important to know as well that the eye problems can usually come after the other problems with the inflammatory symptoms. So like the back pain, for example, will usually come before getting uveitis. But in saying that, usually it's quite often that people will present with uveitis or an eye problem, and that's what prompts them to be tested for things like ankylosing spondylitis. So as an optometrist and all ophthalmologists and eye specialists, they are quite important in identifying the disease, because it often prompts the diagnosis of it, because they don't really know they have it before that. They might just think they have back pain and just be brushed off. So this is a list, not an exhaustive list, but this is a list of all of the ocular complications that can happen with AS. Obviously, you're probably all aware that the uveitis is definitely the most common with AS, so I'm going to go through that the most and in much more thorough detail than the others. But all the other ocular complications, so like the episcleritis, scleritis, keratitis and orbital inflammation, they've all been mentioned in the literature that have been related to AS, but they're definitely not as common as the acute anterior uveitis. So I'll go through them one by one. And before you understand a diseased eye, it's very important to know what a healthy eye looks like. So I'm going to go through a little anatomy lesson. So this is an eyeball. The front of the eye is obviously here, and this is the back of the eye, and this is the connection that will go to the brain. So in uveitis is technically a group of conditions that involve the uveal tract. So the uveal tract is all the blood supply. So the choroid, which is what supplies blood to the retina, and then that extends to this part of the eye. This is called the ciliary body and ciliary muscle, and also connected to the iris. So all of those structures are called the uveal tract, and an inflammation in any of those, or all of them, is called uveitis. So that's essentially what uveitis is. And usually uveitis is associated with inflammation of structures next to the uveal tract. So if this part of the eye is inflamed, sometimes the jelly next to it might get inflamed because of it passes on the inflammation next to it, and the retina as well, and the optic nerve. So anything close to the inflamed area can also get inflamed. Any questions so far? No? Okay, so acute anterior uveitis, or AAU, most people know it as iritis. It's also called iridocyclitis. Not many people call it that though. So this type of uveitis is definitely the most common form, and it's like the hallmark eye manifestation of ankylosing spondylitis. And in particular, ankylosing spondylitis. So between about 30 to 40% of patients will eventually get an anterior uveitis, which is really high. Usually it's in males more than females, and usually young adults between about 20 and 40 years old. But again, not everyone conforms to the textbook, so it doesn't mean just because you're not in that group doesn't mean you're not going to get it, but that tends to be the majority. So like I said earlier, the uveitis symptoms might actually come before any other clinical features of the spondyloarthropathy, so it doesn't have to be the other inflammatory processes before uveitis. You can also get this before, and like I said, as well as people who present with anterior uveitis, about a third of them will have AS, which is really high. So it's really, as an optometrist and teaching other optometrists, we should always be asking other questions other than just trying to fix their eye. So like I said earlier as well, this tends to occur at an earlier age if you have ankylosing spondylitis. Idiopathic uveitis is just uveitis that happens just because, and that's actually the most common reason people get uveitis. This just happens and they don't know what happens with it. Like, it's about 50% of people will just get it for no reason. It can also be caused by things like trauma, so you're getting a big whack to the eye, you can get uveitis with that, and trauma like surgery, so having eye surgery can cause inflammation, or it does cause inflammation, and it's very, very common to have that. Any sort of infection, so like in particular like syphilis, that can cause uveitis, and idiopathic again, that's the most common cause of it, which is just because. And it all can vary, so like you can get it suddenly, or it can just like slowly creep up on you. It can be really acute, so it only happens for a few weeks, or be really chronic, so keep, no matter the treatment, just keep going on and on and on. And sometimes it can keep recurring, or just like kind of be lingering at a low grade. So it varies with everybody. Blurry image varies at the bottom. But this is essentially like what the general population would see when you get uveitis. So it's just like a red eye. So a red eye is an emergency. Like you should see someone if you have a sudden onset red eye, especially. So it's really hard to know if it's uveitis just by looking at it like this. So there are definitely techniques that optometrists and some really good doctors who have a slit lamp can use to actually properly diagnose uveitis. But this is essentially what it can look like. Some people don't even get a red eye, like this other half of the photo here. Some people who get uveitis often might actually not really get a really red eye, so it doesn't actually have to be completely red. And some people, the redness is only around the rim. So like usually it's more constricted around the iris, around this part, because essentially the iris is the part that's inflamed, so the redness is usually more concentrated around that part of the eye. So going through the symptoms, what you would experience with uveitis, anterior uveitis, so definitely a red eye. It's usually painful, so it's usually really achy, like a bruise. So like being punched in the eye, if anyone's experienced that, or just what you would feel like being punched in the eye, like a deep pain. Not so much like a scratchy or like it doesn't usually feel like there's something in your eye, but it's more achy. light sensitive, so which is technically called photophobia, so looking at a light or going out into the sun or in a bright environment, it gets worse, like it feels really sore and you want to close it. It doesn't get sticky, so it doesn't have any thick mucus stuff coming out of it, and it doesn't get, you know, conjunctivitis-y. It can be watery, but that's not generally the most common symptom. The vision can be very blurry. Some people don't notice any change to their vision, but some people get really blurred vision, so it varies. And both eyes can be affected, but it's usually one, especially in AS, but both can be affected, which can be quite painful and annoying. And it's really, I did put in bold down the bottom here that using a slit lamp is really important to accurately diagnose uveitis, because you just can't see the cells or inflammation without it. So this is what a slit lamp is. These are some examples. So essentially you put your chin here and your forehead on the top bar, and then this is where the optometrist or ophthalmologist will be, and they'll be looking through the microscope at your eye. And you get up to 40 times, sometimes more magnification. This is one with a camera, which is really good to document the severity of the disease and check the improvement of things. And so obviously that's taking a photo of the eye. So it's very important to use a slit lamp. Some doctors definitely have one. Obviously they have to know everything about the whole body, so they don't concentrate a lot on the eyes. Some of them are really good, they can use them, but generally they would usually refer to confirm the diagnosis. And hospitals should have these as well, so definitely in a city hospital they would be really good at this, but in country and rural settings usually the optometrist is the one to go to. Well, I would definitely suggest that. So I'm going to show you what we see when we look into a slit lamp, because the hallmark sign with uveitis is cells, so literally seeing the cells of inflammation floating in the eye. And but the cells are actually like a breakdown, so it's actually leakage of the inflammation from the breakdown of the blood vessels in the iris. And it just like leaks the inflammation or cells into the clear fluid in the eye. So let me just go back to this. So because of the inflammation, the iris blood vessels become leaky essentially, and all the cells leak out and they float around in this front part, so where all the fluid is, or all the clear fluid. So I'm just going to go through a video. That's not what I wanted to do.
What cell and flare looks like under the microscope. Now this is an eye with a lot of inflammation, and the best way to see cell and flare is to shorten your beam like this, angle it such that one side of your light beam is on the cornea to the left of the pupil, and one is on the right to the right of the pupil. It's easier to see individual cells floating here with a black background of the pupil. If you make your beam a little bit wider, it's even easier to see these individual cells floating here. This is another eye with less inflammation. It's even more important to make our beam kind of short and a little bit wider. And you can see there's a lot of flare here. It looks like smoke. And you can see the individual cells.
So this is obviously directed at optometrists and ophthalmologists. It's hard to really get what you're looking at if you don't use a slit lamp very often, but can you guys kind of picture what we're looking at? So the cornea, which is the clear layer of the eye, is this front beam, and then this is the iris here. So we're focusing the light in between that clear section at the front, and you can see how small. See these little specks through here? That's the cells floating around.
Floating as well. Here's another eye. Not quite as much flare, but you can
So
see
you
the
can see
cells
lots of
really
cells
pop
there.
out.
That's
and
actually
be
quite a
wide.
lot.
And you can see that they're floating upwards in the back, and they're floating downwards in the front, and that's because of convection currents, because it's warmer in the back of the eye.
Watch more. So there you go. I thought you'd be interested in seeing what we see there. Let me go back to my... Oops. Swap display. Here we go. Okay. Any questions? Does that make sense? So it's really hard to see those cells without using that 40 times magnification, because technically if you have cells you've got uveitis. So if you don't have the cells, like, you don't have it. And we grade the cells based on how many there are, so sometimes there's one random cell that floats around, and that's technically still classified as uveitis. And that might be at the end of the condition where it's, obviously getting improved. And sometimes there's, hundreds of cells in the front section, just in that tiny little beam. Counting them in that one little millimetre section is how we grade them. So, and that's based on, and that also bases the treatment for it too. So depending on how many there are, bases how regular you use eye drops and all of that stuff. And it's all definitely a case-by-case basis. So there's no textbook answer for every single diagnosis, which is really important to know as well. So, and that's why we like to monitor ongoing, just to make sure the response to treatment is appropriate. Or flare is like a leakage of albumin, they call it. So flare, cells and flare. So cells are like literally the dots, and flare looks like he said in the video, like a smoky appearance. They're just not clear. So your vision, because of all that haziness, your vision usually is blurry from that. The other thing you get in uveitis is keratic precipitates, or KP as we call it, which are actually deposits on the inner part of the cornea. So this photo shows, let me get my ruler. So this is the front layer of the cornea here, and the light beam is passing through, showing the thickness, and these little dots are actually deposited on the back surface of the cornea. So because it's inflamed, like all the cells and inflammation kind of just deposit themselves and sit themselves on the back of the cornea. Usually you see that if the uveitis has been there for a little while, but it can come on quite quickly. So this is very obvious. This isn't an ASI, by the way. They don't look like this in AS, but I was just showing a very obvious, a KP photo, so you can see how it's just all over the cornea. And you would, if anyone missed that, that would not be very good. This is more what AS looks like, so it's usually really fine little deposits kind of sitting at the bottom. But again, not like, it doesn't have to be like that. There can be only one, or be like really even finer than that, and really struggling to see it with a microscope as well. So it doesn't all have to be there. And this is another photo of inflammation, obviously, but it's all settled. So this is all the cells, because there's so much and so many cells that it's actually settling right in the bottom of that chamber at the front of the eye. So that's actually called a hypopion. The other part of this photo that I wanted to demonstrate was an irregular pupil, because of the posterior synechiae, which is actually what these little adhesions are. So they actually stick to the lens, which is, let me go back to this photo again. So when it gets really sticky and inflamed, this iris, because it kind of rests on the lens, this is the lens, so that's a clear structure that sits inside the eye. The iris gets so sticky that it sticks on the lens. So there's little parts of it that actually stick down, and when the pupil tries to get bigger, it doesn't widen with because it's all stuck down. So it looks like that. So it's really uneven. Sometimes it can all be stuck down, which is not very good at all, because that means there's no transfer of fluid from behind that iris, because that's what regulates pressure. and your pressure will go up a lot, and that's not good. I'll go into that later too. But yeah, that's quite a common finding, irregular pupil or the adhesions. And you can probably see that if you looked at someone really closely without a slit lamp, you'd be able to see their pupil being a little bit funny shaped, depending if their iris is really light. This is called fibrin. So fibrin is a sign of quite significant inflammation. So you can see all in this is actually sitting inside the clear layer, like not the cornea, so in like the clear fluid where the cells are. So it's just like all bunched up and just floating in there. It's like a big clump of inflammation. This is actually what this is from our files at work on a patient who had uveitis. So she has some fibrin all sitting in the anterior chamber there, which is quite a nice photo. So I'll just put that in there. So in ankylosing spondylitis, the anterior uveitis can have a certain pattern. Usually it's in one eye, so rather than being in both eyes. So unilateral alternating means it's in one eye and then it can go to the other eye. It kind of alternates eyes. That's usually a pattern they've found in the literature. It's usually acute, which means it comes on suddenly and it's there for a period of time and it goes away with treatment, but it recurs. So you get it and you get it again and you get it again, rather than having it and then it lingers and stays there for a long time, which is called chronic. And like I said before, the KPs, which are those spots on the surface, so in AS they're usually more fine rather than the mutton fat KPs. That's what they are called in optometry. And you get fibrin, which I showed you earlier, which is this, and the hypopion, which is that bit of inflammation that settles down. So, but again, you don't necessarily have to get all of it, but they found that that's quite a common picture of uveitis in ankylosing spondylitis. And it's quite interesting, I didn't know this, but in the literature they do say that it recurs, there's like a pattern with AS, so it recurs several times in the same eye, and then it goes to the other eye, and then it goes back to the other eye that was originally affected. So that's quite interesting to know. Okay, so treatment. Now, definitely all uveitis can be treated. Sometimes the treatment doesn't work as well as you'd hope, but if you get to it early, that's definitely the best chance of full recovery. So, and it definitely can be treated by an optometrist who has therapeutic endorsement, which is most of them these days, or a GP with, obviously they would probably call an eye hospital to advise of, to make sure they're doing it right, or an ophthalmologist, which is an eye surgeon. So usually if there's inflammation, you get anti-inflammatories, which is a steroid. So a very potent steroid is required because that's the only thing that will penetrate through the front of the eye. So the cornea at the front here, the clear layer at the front of the eye, the inflammation is behind that. So it's in here and sometimes here and sometimes at the back. But to be able to get through the cornea, there has to be a certain strength of steroid to penetrate. So weaker steroids definitely will not work. Like, you have to be on the strongest to be able to actually pass it through to treat the uveitis. So a potent steroid is called prednisolone forte, which is my favourite. That was actually unavailable in Australia for the last 12 months, unfortunately, so we had to use Maxidex, which is very similar, so pretty much the same, but it's only just been coming back, Pred forte, which is really good. So usually, depending on how severe your uveitis is, would be dependent on how frequent you put the drops in. So with pretty moderate level of inflammation, we would probably go every hour, 1 drop every hour, or 2 hourly. And if it's really significant, like sometimes you load it up every 15 minutes for a few hours and then go to hourly. You don't have to wake up usually during the night to put it in, it's just during daylight hours, but this is usually goes on for how responsive the uveitis is to the treatment. So usually you want to go down 2 grades of cells. So like say you have 50 cells and you go down to 10 cells. and then that would prompt you to reduce the dosing of the steroid, but everyone's different. If you stop too early, like if you slowly or you suddenly stop the steroid without the inflammation fully gone away, or if you come off too quickly, the inflammation will just come back. So it's really important to do it slowly and properly, and that's why you don't just treat it and see you later. You have to monitor it until it's fully resolved, because chronic inflammation and inflammation that keeps coming back isn't good. We want to keep that resolved and keep it away as much as possible. And I'll go through complications of inflammation as well in a few more slides. So some people actually need a steroid all the time. Some people have chronic uveitis, and as soon as they come off their drops, it comes back. So some people have a really weak steroid that they use like once every 2 days, just to give their eye just that little bit of attention or anti-inflammatory action, so that stops it from wanting to flare up again. So I've got a few patients that need that, but generally the first time you get it, you'll probably be okay, and you don't need to stay on long-term drops, because again, you don't really know that it's going to recur, and so you wouldn't just keep someone on that just in case. You got to kind of go case by case basis. There's also a drop that we use to dilate the pupil, so that's especially when you have the irregular pupil, we can actually break that. So there are drops, specifically atropine drops, which act on the iris muscles to dilate it, so the muscle goes out here, so your pupil goes really big, and so then it theoretically stretches these and pulls them and breaks them away. So usually you have more chance of breaking them earlier, so if they get really sticky and really stuck down, they sometimes don't break. If they do stay there, it's not really a problem, it's just a problem if you don't like the look of it, I guess, but unless it's all stuck down, your eye's actually still functional. You can still see, providing there's no other complications, so it's not the end of the world if you don't break them, but it's just nice to break them, because you don't want to, and it also prevents them from forming. So if we dilate that pupil and keep it moving, because obviously the drops will wear off and it will start to go back in again, if you keep that muscle moving, it stops the muscle from wanting to stick down, rather than keeping it in the same spot and giving it a chance to stick. Some people don't need the drop to dilate the pupil, so you can just have the steroid depending on the severity of the uveitis. The pupil drop also helps with pain though, so because it actually stabilizes the muscle. Because the reason why you get light sensitive is because this muscle is inflamed, and that's the muscle that moves when you look at light. So your pupil gets smaller when you have a bright light and larger in the dark. So if your pupil is moving, and if you have a sore arm and you move your sore arm, it hurts. Or if you have an inflamed arm and you move your arm, it will hurt. So same with the eye. So that's why the light sensitivity happens. So when we make that pupil still and not move, it helps with the pain. So sometimes this isn't enough either, so you might get to a point where the inflammation just isn't getting better, or it's hit a plateau and it's just not improving. And sometimes you actually need an injection of steroid into the eye, which sounds horrible, but we as optometrists can't do that, so that's an ophthalmologist who does that, because they're a surgeon, so they actually literally stick a needle into the eye full of a steroid, and hopefully that's enough to get rid of the inflammation. And you can have a few of them. And then obviously tablets form, so if everything else fails, we go to tablets, like prednisolone for example, which you usually want to avoid systemic medication if you can, but that is an option still if everything else fails. Some people actually need like an ongoing immunosuppressant, so like methotrexate or a biologic like Humira, and I've got a lot of people who are on Humira, but that would be in conjunction with your rheumatologist, which I'm not going to go into that because that's outside my scope. So it's really important to know in AS, and even if you don't have AS, that recurrences of uveitis is really common. Some people get it, 2 weeks after they've finished their treatment for their uveitis. Some people might get it 5 years later. It really, there's a really high chance of it recurring again, especially if you're HLA-B27 positive. Some people just know that they're getting it. So even before we can see that there's uveitis there, some people just get this twinge, or they might feel stressed, and they think that, like lots of people do say that stress brings it on. There's no evidence of that, but lots of people say that. So often people who get it a lot, we usually give them a prescription to keep on hand because they know that they're going to get it, and then they can just treat it themselves. That isn't really appropriate unless they've had uveitis a lot and they know exactly what the symptoms are, because self-treatment isn't always the go-to. We don't usually recommend that, but definitely for these cases, like if they just know and they've got all the risk factors there, like you just want to get onto that inflammation straight away. So usually you can kind of stop it from coming on. And like I said, sometimes the uveitis can be unresponsive, so no matter how much what you do, it just doesn't resolve, which is really important to know about the complications of that, so I'm going to go through that as well. The first attack, in the literature, lots of papers actually mention that it can be misdiagnosed as conjunctivitis. So this is actually a conjunctivitis photo. So it doesn't actually look that different to uveitis. So often if you see someone like a medical practitioner who might not do eyes all the time, and they don't have the facilities to look in the eye, it's really common for them to just say conjunctivitis. And they'd probably put you on like Chlorcig or something that won't help inflammation, and potentially that would, because you're not treating the uveitis, you'll get worse, etc., etc., etc. So it's good to diagnose it properly first. Preventing uveitis isn't really a thing. It is, but it isn't. So it's really depending on your case by case, on like your situation. So because it's impossible really to predict when a recurrence is going to occur. So if you want to go on strong medications to prevent recurrences of uveitis that you don't even know is going to happen, like the side effects and risks of that need to be weighed up. Because sometimes, most of the time, the recurrences of the uveitis don't actually cause any problem with society. So, why would you go down the road of systemic medication if it's not really, like preventing the issue isn't really, worth it? So it's all a bit in the air there, depending on how bad you get it. But people do go on drugs or go on certain medication to reduce the attacks of their uveitis. But again, that would be in conjunction with your rheumatologist that you would discuss, because it's very expensive too. So all of that needs to be taken into consideration. Now, I'm going alright for time. That's good. So, complications of uveitis. Now, the structural complications usually come when you have really severe attacks and when you have a lot of them. So the more you get it, obviously, the worse your eye is probably going to be. You can actually lose vision, like permanently, so you can go blind from having uveitis, or permanent visual impairment, like if it doesn't fully resolve, like your vision might not ever be the same. So it's really important to understand what can happen, because that will help people to go get an appointment to be seen and not just brush it off and say it's going to be okay, because most of the time, yes, it will be okay, but you just don't want to be in that group that loses vision. So like I said earlier, irregular pupil, that's quite a common thing to have permanently after uveitis, because the inflammation sticks everything down, and if it doesn't get broken, it just stays there. So that's like a less serious complication. And because of that, like I said earlier, the fluid that produces or that regulates your pressure in your eye can't get out. So it will make your pressure really high if it's all stuck down, and that's another complication of uveitis, which is the pupil block. That's what I mean by that. The other thing that can cause eye pressure to be higher is the steroid drops that you use to treat it. So some people, it's really common actually, like about 30% of the population, I think, will actually be a steroid responder. So that means their pressure just goes up because of the steroid. So, but that wouldn't stop you from treating it with a steroid, because the inflammation is definitely worse than having high pressure, because you can treat the pressure. But having high pressure is a side effect, or can be a side effect, and if it's there for too long, it can actually cause glaucoma. So high pressure doesn't mean you have glaucoma. It means high pressure can increase your risk significantly of getting glaucoma. So the longer your pressure is high, and I mean like for not just a day, you know, months to years, that is how you get glaucoma. So this is a little summary of what glaucoma is. This is the nerve that connects the eye to the brain. So this tissue around this, so this pale section here, that's kind of like a cup which got nothing in it. The tissue around it, that's actually the nerve tissue that gives peripheral vision. So all of this tissue is providing your peripheral vision. Now with pressure, because that's a very sensitive structure of the eye, if the pressure is too high, it's like strangling the eye, like it's like under, you know, really deep water, like essentially under a lot of pressure, and they start to die. So you start to lose this tissue, and that's this. So that's very thin, and so the central section is a lot bigger because essentially there's no tissue, and therefore you start to lose your peripheral vision. So this is like tunnel vision. So this is normal vision, vision with glaucoma. And that's quite exaggerated. That's pretty end stage glaucoma. So that you don't want that, because that can't be reversed. So once the damage is there, you can't fix it. So definitely seeing someone about your pressure, or just getting general eye checks anyway, just to check that the pressure is not high, is really important, because you can't actually feel it, like having a high pressure, unless it's really, really high, but you don't really know that it's high. So that's again why eye examinations are really important. Cataract is another complication of uveitis. So usually from the steroid drops that we treat it with can cause a cataract. So PSCC, that's an acronym for posterior subcapsular cataract, which is a type of cataract that affects the back of the lens. So this is a really nice photo of a cataract. Obviously the pupil has been dilated, but you can see that the lens behind, or the clear lens at the front of the eye is not clear. It's really cloudy. So that's exactly what a cataract is. Cataracts are nothing to worry about though. So if I had to choose something that's wrong with my eye, I would choose a cataract, because it's super easy to fix. And every single person in the world will get one if you live long enough. So it's actually happens anyway, but it can happen a lot quicker if you treat it. That can definitely exacerbate the timing that you get cataracts. But it can definitely be fixed. So all they do is they just take the lens out of the eye and put a new one in, like a fake one that's clear. So definitely nothing to worry about with cataract. It just makes your vision blurry, and I'll show you that. So this is very exaggerated, but does paint the picture well. So obviously nice clear vision. You can see that lovely lady there. And this is the white blindness, so it's all like foggy and like looking through a cloud. That's typically what a cataract does to your vision. This is probably more realistic with glaucoma than the other photo, so it's not usually like black. Usually it's kind of just missing. So this is very advanced glaucoma. That's very quite advanced. So essentially like you just see the middle and not the periphery. But that just gives you a little example of what happens when you get cataract. Usually people would come in before this, so you'd start to notice your vision's a bit foggy, and you know, probably see someone before it gets this bad. But it can still be operated on. It doesn't really matter how bad it is. The operation's the same. Your vision just is really bad. So the other complications that can happen is called CMO, or cystoid macular edema. So the macula is at the back of the retina. Let me just go back to this photo. So the retina here, So the macula is the very middle part of the retina, which is where all your detailed vision comes from. That's the centre of your vision, right at the back of the eye. So when you look at something, you use your macula. So it's very important for detail. So you would, if you didn't have a macula, or it was destroyed by some sort of disease, you wouldn't be able to read. You'd see like movement and things, but you wouldn't be able to see detail, recognise faces, that kind of thing. So macular edema is this inflammation of the macula. So this is a normal macula, this is an OCT scan. So this is like an X-ray that goes behind the retina and gives us layers that we wouldn't be able to see just by looking in. That's a normal macula, very healthy. This is macular edema down here. So you can see that it's lots of spaces all within the layers, like that's all pockets of fluid, and the normal contour is really disrupted. So, you know, that's right, that's like a blob in the middle of their vision, essentially like this. That's quite a good example. Some people might be a bit grey, like a grey blob in the middle, but generally it's, you know, you still see everything out here, but the middle section is blurry. This is very different to macular degeneration. So macular degeneration isn't to do with any inflammation or uveitis or anything. It's actually the degeneration of this layer here with age. Age is the most common reason for it. And it just breaks down and it doesn't work as well, so you get little lumps and bumps through here. It doesn't usually, well, it can cause fluid here, but it's for a different reason, not inflammation. This is another really nice photo actually of neovascularization of the retina and the optic nerve and the iris. So this is an iris, as you might all know now, and we can see all of the blood vessels that are growing through it, which are new blood vessels, which if that happens, it's really bad sign. Probably the eye is like dead or about to die. The pressure will go very funny, but yeah, that's not a good sign. So this is like, you know, quite rare to see, but good for you to just be aware of it. The retina can also grow random blood vessels that aren't supposed to be there, so all these curly ones all through it, they're new blood vessels that aren't actually supposed to be there because the eye's kind of under stress and it needs to fix itself, and it's trying to provide nutrients so it grows its own blood supply, thinking it's doing a good thing, but it's actually not, because they can be really leaky and leak fluid and your vision goes really bad, and the blood vessels can grow all through the drainage structures of the front of the eye, and that makes your pressure go really high, so it's all not good from here. And this is a retinal detachment, so this is like, these are all, again, rarer complications, but again, can happen. So this is a photo of the back of the eye. This is like a little skin, essentially like a top layer that's kind of falling off. So that's quite a good photo of a retinal detachment. Hypotony means the pressure is so low that the eye is dead. So it can't keep its structure, like it kind of collapses on itself. And that can happen after this. So this is what happens when you have a retinal detachment. Is you usually get a curtain over your vision, so the curtain coming down, you know, like usually a grey or black curtain, usually flashes as well, like lightning strikes, but definitely any symptoms before this, like floaty things in your vision suddenly, especially, or lightning strikes, you would hopefully see someone before this happens, because it's really hard to put that back on. You can, but you don't usually get the same result. Now this is a little bit extreme, but I just wanted to show you what could happen if you just don't do anything about any eye problem. Essentially this is like a blind eye. There's no way you can see through that up the top. She's actually got a prosthetic eye, so looks quite good these days. Prosthetic eyes actually look really realistic.
Wow, you wouldn't know it.
No. Yeah. So that's her actual eye before a prosthetic eye. Most people take their eyeball out, a prosthetic eye, they clean it and put it back in. But yeah, that's a very end stage, you know, usually third world country kind of situation. But just good to know that, you know, inflammation ongoing and severe can turn bad. And essentially out of this top eye, I was trying to emulate what people would probably see out of it. Probably, to be honest, not even this with that. Like if it was a bit less opaque, this is essentially like just blur of colour. Like that's definitely legally blind. So you just wouldn't be able to really do anything. You'd have to learn, Braille and have a dog, a seeing dog. You wouldn't be able to drive. You wouldn't be able to look at your phone. All those things that we usually take for granted. Vision is very important for. So I don't want that to happen. Now I'm going to briefly go through the rest of it because this isn't as common in AS. But I just want you to know what they are. So this won't take very long. And I'm about 52 minutes, so I'm kind of right on time. So intermediate uveitis, posterior uveitis, and pan uveitis, they're all they're called that based on their location of inflammation. So I'll just briefly explain it here. So anterior uveitis, which is what I've been going through earlier, happens at the front of the eye. So anterior means front. So where the iris is. So intermediate is the jelly of the eye, like the eyeball is full of like a jelly structure. And then this section, which is near the front part, like so in the intermediate zone, that's also affected in intermediate uveitis. And then posterior uveitis is the back, so the retina and the choroid. I'm just going to cough, sorry. Tickle in my throat. I don't have COVID. The posterior uveitis means, inflammation at the back. Pan uveitis is everything. So iris, vitreous humor, which is the jelly, and the retina, all of that inflamed is pan uveitis. So that's really rare and really severe if you have it. So that's essentially what all of those conditions entail, is the location of the inflammation. And they're all much less common than anterior uveitis. So I have seen them definitely before, but definitely not as much as anterior uveitis. And it's not really commonly associated with the seronegative spondyloarthropathies, but there have been cases, so you just got to be aware of it. So in particular, posterior uveitis, which is right at the back, usually that's not really a AS or an other spondyloarthropathy thing, but again, has been reported. Definitely more likely to cause loss of vision, these two, because essentially the treatment is much harder because drops do not get to the back of the eye, so you have to definitely go see an ophthalmologist and combination of rheumatologist to get rid of inflammation here. Usually the causes for these are more like MS, sarcoidosis, syphilis, Lyme disease, those kind of things, herpes, toxoplasmosis, those kind of things. So not really AS, but again, we'll go through it. So you don't really get many symptoms with it, like as in pain. So you don't get a red eye, you don't get achy, you don't feel that bruised, deep, achy pain. But you usually get floaters, which lots of people have floaters. Who has floaters here? I do. Yes. So just because you have floaters does not mean you have this, so please don't stress about that. I found a really good realistic image of floaters. This is usually what floaters look like. This is a lot of floaters, so you can see how it's like a just greyish and blobby and like little line kind of appearance, like little wiggles. They're not usually like, they can be like dark dots all scattered around. But that tends to be the most common floater appearance. Mine are probably like that actually. I have a lot of them. And they're very annoying. So the other thing that you usually get is obviously your vision gets really blurry, or just, can't see much at all. And what we see as optometrists when we look in is lots of little blobs at the back of the eye, like white little spots or yellowy whitish spots, and lots of swelling. So usually the optic nerve is a bit swollen. So I'll show you some photos. This is actually a healthy eye, so there's nothing wrong with this picture. This is just showing a image of the back part of the retina. So optic nerve, macula, blood vessels, and that looks really nice and healthy. This is the same camera but puts two together. So we have this camera at our eye centre. Really nice and clear photos. and because of the high definition, it can't take like a really big wide field, but the old cameras are only about 30 degrees, so they only usually take about this much. So this is a lot bigger, but we can make it even bigger by stitching them together, and there can also be more than that, so 5 photos can be stitched together as well, which is really nice to document any inflammation in the back of the eye. This is another camera that we used to have before we upgraded, but this gives them really nice wide field, but the detail in the middle isn't as good, but it's really nice to see the peripheral area. So again, this is a normal eye. Now, this is not normal, so you can see little white spots all scattered throughout the back. This was like mainly scattered just inside the eye. Let me just go back to one of the diagrams because it's hard to really get where that is. So the inflammation that I just showed you is actually all here. It's all like scattered just behind. So when you look in to the eye, you have to really look here to see there. Like you have to get the patient to look really far, up, down, left, right, and you'd have to make the pupil big. And sometimes you have to actually push in this part of the eye with a special instrument to be able to get it into view. So looking for this inflammation can be quite hard. So if you don't look for it, you're not going to see it. But if there's inflammation just here, usually that's not as common. Usually you get it everywhere else. So you would usually go looking for it if you see inflammation somewhere else. But that's called snow banking. So it's like snowballs that kind of sit all through here. So this just gives a nice little photo of that. And that's like intermediate uveitis. Yep. So there, and again, similar thing, a little bit blurry, but you can see like the white lesions here. So if you only really looked here, you probably wouldn't really see that. So brief looks are not good enough. You've got to look hard. These are very obvious, so if you miss this, you probably should be deregistered. But the obvious white lesions all through the back of the eye there, that's all active inflammation, and yeah, same here. That's generally this is kind of like a view from the patient, what they might see with that. There's little, obviously, inflammatory blobs in the back of the eye would affect your vision. So this is very exaggerated, this is quite bad. But even things like diabetic retinopathy, which is a condition of the back of the eye with diabetes, they usually get things like this. But essentially, you know, you don't want that. you don't want your vision to be like that permanently. Any questions so far? No? Cool. The other things that can occur with AS, but not as common as well, but still worth mentioning, is episcleritis and scleritis. They are quite different, but I did group them together because they're still kind of similar. So these are definitely not as common. It's actually more with inflammatory bowel disease, but still has been reported. Episcleritis is actually really common in normal population anyway, even without any condition. So it like happens quite a bit. I see it very often. This is what it looks like. So little section of the white part of your eye just gets inflamed and red. Usually the symptoms of this are like a little, kind of like an ache maybe, sometimes not, sometimes it's a bit gritty, or just like you're just aware of it, not usually like really bad pain. Some people who have low pain threshold might feel like it's really bad, but it's not, you know, the end of the world. It's just like localized inflammation of the front white part of the eye. And usually it goes away in like a week or so by itself, but sometimes if it, you know, really annoying the patient, or if you just want it gone, you can treat it with an anti-inflammatory, which will definitely take it away. But most of the time, just using like lubricants will just make it feel better if it just goes away. And some people get this quite often. This is a similar photo, and again, same thing. So just this little section of the white part of the eye that's red. Some people get this often if they have like a pinguecula, which is like a little lesion from sun exposure, usually like a little raised area on the white part of the eye, and that can get like inflamed. So that's kind of a form of this, but actually called pingueculitis. But again, there's lots of tangents we can go on with these. This is scleritis. So scleritis is much more severe. It's involving a deeper structure, so is really painful. It's like a deep part of the white part of the eye, which actually extends all the way around the whole eyeball. So you can see this bluish tinge here, and that's like quite a obvious sign that it is scleritis. You don't get that with episcleritis. And vision is usually really blurry, and when you move your eye, it's really painful. And usually these are really in association with something else going on in the body. So any of these you send on to get blood tests and see a specialist. Some people just get it for no reason, but usually it's like from like Lyme disease or something bad. Keratitis is an inflammation of the cornea, so the front section of the eye. So if you have something like this, usually you're going to get inflammation of the cornea. So usually it's in conjunction, but often it can also be by itself. But again, uncommon in AS, but just good to be aware of it. So just like some ulcers, hard to really see properly, but that like bluish area down the bottom, that's an ulcer, which is like essentially the cornea has like a divot in it, like a hole in it essentially, and it's really inflamed and sore. And this is like more of a peripheral area, it's a bit less obvious, but that's an angry eye. If that happens right at the front of the eye, so over the pupil here, if that scars, you can't see through that. You don't want that to happen. So again, early treatment's really good. And then orbital inflammation has been mentioned. This is really rare, really serious. I've seen it maybe once, but that was because I already knew they had it. But it tends to happen with uveitis. It doesn't usually happen just by itself. So obviously you'd look for this as well, but it would be quite obvious because usually you have like this asymmetry. So you can see there's something going on with his left eye there. This is MRI. You can see this white inflammation all through the orbit and also the optic nerve as well. This is his optic nerve. That looks very, very inflamed. That's just raised. So that's really serious. Probably no real recovery. A little bit of recovery maybe, but not nowhere near what the eye would be seeing before this happened. So that's quite rare anyway. So, but just good to know. Anyway, so take home messages. So definitely, if there's any, the general population should be getting eye examinations every 2 years. If you have something going on in your body like AS or some sort of some other diagnosis, you should come a bit more frequently. So I would suggest annually, just even if your vision's good. So even if you feel like there's nothing going on, it's good to just really look at the whole eye and make sure that everything's stable. Because sometimes there might be changes that happen that you're not aware of. So it's really good to just get it checked. And we'd write a report to your doctor or your rheumatologist just to update them. Just be aware as well of new symptoms. So any redness, pain, blurry vision, anything that's different to your normal feeling of your eyes, please just come get it checked. Don't just put it off. We do have emergency appointments available all day. If you have a red eye or a sore eye, it's an emergency. You don't have to book a proper appointment. You can just call up and say, look, this is going on, we'll get you in. So it's not, as long as you say that, don't just ask for a normal appointment, but please just come in and get it checked, because better safe than sorry. Any questions? Anyone on the live stream?
We have a few.
Oh yeah.
But there aren't any questions. Not that I can see.
Okay.
But wonderful presentation.
Thank you.
Thank you very much.
And thank you for the opportunity, everybody. The references I put there, but I didn't put it through the presentation, which I would if I was presenting at uni, so I'm sorry about that. But if you wanted to look at them, and there's just a little finishing slides. So thank you for your time.